Right, perfect. So we've got more information about the West Center. There's some information on me, our course description, outline and objectives for those of you who are needing CEUs. But let's jump right in. There's 3 different types of care that we have the option for. And so let's start with curative care. Curative care is that care whenever we're focusing on quantity of life. We're focusing on a cure, and we're focusing on prolonging life. There's times for this. There's a time for this. Whenever we can be cured, when there is a cure for the disease that our loved one might have or we might have. But it can also cause more suffering when a cure is no longer possible if we continue to be in the mindset of curative care. And we can put our loved one through treatments and procedures that aren't necessary. And we can actually extend the period of their suffering if they have a terminal illness. Some of the things that are included in curative care might be respirators, IV treatments, infusions, tube feeding, central lines, resuscitation. This is when we don't have a DNR, a do not resuscitate, and we are calling a person a full code. We are going to try to extend the life for as long as possible. So again, with curative care, it focuses more on quantity of life. Lots of times what happens with curative care and what I've seen happen in my career is a family hasn't done their paperwork. Someone doesn't have any advance directives. There's not a living will. And nobody will step up and make a decision. And they have a loved one who ends up on life support or with a feeding tube. And then they're standing back going, they didn't want that. They always said they didn't want it, but nobody would make a decision. This can be a really hard time. Let's look at the next type of care. This is palliative care. Many times whenever we choose a hospice, it will say that it is a palliative and hospice care. So let's look at what exactly is palliative care. Palliative care is going to focus on that comfort and the quality of life and the quality of death. And you can still be receiving treatments while you're on palliative care. Palliative care really views death as a natural part of life, and palliative care comes in and helps alleviate a lot of the pain and suffering. It lessens and relieves that physical and psychosocial and spiritual suffering. It gives the patient the permission to accomplish their goals and have some life closure. This is the main thing to take away from palliative care. You can still be receiving treatments. So a person may be on chemotherapy, or they may be on dialysis. They may still be receiving treatments of some type and be on palliative care for pain and for comfort. And then there's hospice care. So what does hospice care focus on? Hospice focuses on comfort and quality of life. We're going to look at the 10 biggest myths about hospice. And one of those myths is hospice is when you've given up. Hospice isn't about giving up at all. Hospice is about quality of life and comfort. We choose hospice care when there is no longer a cure possible. We choose hospice care when, with all specialized services and all specialized care, our loved one or ourselves, we are not getting better. It is intended for the final months of life. We hope that people will be on hospice care as soon as they're eligible for it, and we're going to look at what that means. But let's start with kind of a history of hospice, and you might recognize that word from hospital and hospitable. They all come from the word hospice. So let's look at it. The word hospice is Latin, And it came from, the word meant guest, visitor, stranger, or host, because of what would happen when crusaders were traveling on their way to the Holy Land. They would find places of refuge and monasteries, and they became known as a hospice because it was a place to rest. I love that. It's a place to rest. Because great numbers of the pilgrims were in ill health, many of them ended up spending their last days at this place that they called a hospice, a place to rest. So let's talk about, how did it turn into what we know it as now? Dame Cicely Saunders introduced hospice to the United States while visiting in 1963. She had actually established the first purpose-built hospice, a building specific to hospice in London in 1967. So if you think about this in history, that wasn't that long ago. Listen to her philosophy. I've got it in red. You matter because you are you. You matter to the last moment of your life. We will do all we can, not only to help you die peacefully, but also to live until you die. That sums up hospice right there. That is powerful. To die peacefully, but to live until you die. This was in 1967 in London. She lectured. She talked about this holistic hospice care to medical students and nurses and social workers and chaplains. She showed the difference with pictures of terminally ill cancer patients and their before and after symptom control. And this set off a chain of events to how we know hospice today. So in 1965, she came and visited the Yale School of Nursing. In 1968, the dean of the Yale School of Nursing took a sabbatical to go work and learn everything they could about hospice. And then in 1969, this was the changing point in the United States. Dr. Elizabeth Kubler-Ross, many of you know that name, published the book on death and dying. Got it sitting right here on my shelf. And it identified 5 stages through which the terminally ill patient progresses. Keep that in mind. She wrote about what the patient was going through. It became an international bestseller and is still used and referred to today. And for those of you who need a reminder, those 5 stages that she identified: denial, anger, bargaining, depression, acceptance. And then as she continued to work with a gentleman named David Kessler, they created a sixth stage called meaning. We'll talk more about that. In 1972, Kubler-Ross testified at the first national hearing about death with dignity. It was conducted by a U.S. Senate Special Committee on Aging. And listen to what she said. Again, I've got it in red. You're going to get these slides later today. This still applies. We live in a very particular death-denying society. We isolate both the dying and the old, and it serves a purpose. They are reminders of our own mortality. We can give families more help with home care and visiting nurses, giving the families and the patients the spiritual, emotional, and financial help in order to facilitate the final care at home. That was in 1972. In 1974, the first American hospice was opened in Connecticut, and it was called Connecticut Hospice. And in 1974, the first hospice legislation was introduced to provide federal funds to support hospice, and it did not pass. It was not enacted. Again, this was not that long ago in history when you think about it. Now, 1982, Congress introduces a provision to create a Medicare hospice benefit in the Tax Equity and Fiscal Responsibility Act of 1982 with a 1986 sunset provision, meaning that it expires automatically rather than renews automatically. But in 1986, Congress did something. They made Medicare a hospice benefit. The Medicare hospice benefit was made permanent in 1986. Many of us on this call remember 1986. Again, history-wise, it wasn't that long ago. And it took until 1991 for hospice care to be authorized in military hospitals and to become a veterans benefit package. So in 86, it became a Medicare benefit, and in 91, it became a veterans benefit. Here's the most recent hospice data. And as I was saying earlier, we just updated this yesterday afternoon. So we've got the most recent data. In the United States right now, there are over 5,058 hospice agencies. Now, hear this part, 72% are for-profit. 1.72 million patients on hospice last year, these are 2022 numbers, and 65% of Americans die in hospice care. And those numbers went up, and that's a good thing. It's a good thing for those numbers to go up. Let's look at the ages. This was some more numbers that changed. Most people think that hospice, must be with people that are much older, but people die at every age. We've got to remember that. 59% of people over the age of 85 die on hospice care. About 48% between 75 and 84, 37% between 65 and 74. But this number really jumped this past year. 26.5% of people on hospice are under the age of 65. Now, here are some numbers that changed, and thank goodness these are finally starting to go up. About 51% of all Caucasians will receive hospice care. And then these other numbers were really, really low. I've been doing this program now probably since 2014 and have watched these numbers steadily come up. African Americans, we're at about 36% of African Americans will receive hospice care. Hispanics are at about 33%. Asian Pacific Islanders at about 36%, and Native Americans at about 34%. Those numbers are up. And then let's look at what is the hospice philosophy. As we said earlier, all the way back in 1967, this really hasn't changed much at all. It's a holistic approach that encompasses all three of these: physical, emotional, and spiritual concerns. The patient and family are seen as the unit of care. Hospice is not just taking care of the patient. Hospice takes care of the family as well. And we're going to see how they do that. Care is also individualized to each patient and each family. It is responsive to differences in lifestyles as well. Hospice affirms life. Hospice focuses on caring, not curing. By the time a person goes on hospice, we can no longer cure what they have, or they have a disease like dementia that we don't have a cure. But to be able to focus, if we can remember that, hospice focuses on caring, not curing. Hospice provides education and helps the families and the patients understand what this care is going to look like at the end of life. It also helps promote understanding and acceptance that the journey of life, regardless, eventually leads to death. And it actually encourages people to view the experience as an opportunity for growth. The other thing hospice does is it emphasizes ways to make the disease or the symptoms of the disease less severe without removing the cause. Because again, by the time we get to hospice, we can't cure. There's no curing. We're about caring and making a person comfortable while they still live. So they provide physical, psychosocial, and spiritual comfort, and it's delivered by a multidisciplinary staff. We're going to look at what staff looks like on hospice as well. So when do we choose hospice? We're going to look at hospice when medical treatments have been exhausted or the burden of treatment outweighs the benefits. Then it may be time to consider hospice. So let's think about what that means. The burden of treatment outweighs the benefits. I knew someone, known several people who had cancer, and they did treatment after treatment after treatment after treatment after treatment, and they weren't getting better. They were prolonging their life, but there was no quality of life. The burden of treatment started to outweigh the benefit of the treatment. That's what that means. Most people, if given the choice today, if somebody asked you, what would you like the end of your life to look like? Most people would say, surrounded by friends and families at home. Not everybody, but most people. And hospice can help make that happen. When I teach about our 11th hour program at the West Center, I show a person on life support, and right next to that, I show a person who's dying at home with hospice or dying in their home. And their home may be in an assisted living or in a nursing home. There's a difference in what that looks like. Patients and families actually feel like they have a greater sense of control when they use hospice. Hospice will also provide services in nursing homes to ensure pain and symptom management and to provide support to families. We're going to look at all the different places that hospice can go. They can go anywhere the patient is where they can go. And the hospice experience can foster spiritual and personal growth as the hospice team empowers patients and families to manage difficult situations. Let's look at the eligibility guidelines. We have to believe or think, as the healthcare professional, that the patient has 6 months or less if the prognosis of the illness stays on the anticipated projected course. Another eligibility guideline, the patient chooses to forego life-prolonging aggressive treatments for a terminal illness, or there are no treatments. So this might be when someone says, I'm not doing any more chemo. I'm not doing any more radiation. I'm not doing any more dialysis. Another eligibility guideline is that they may have lost 10% of their body weight in the last 4 to 6 months. And then observable and documented deterioration in overall clinical condition in the last 4 to 6 months. I mentioned earlier, we were going to look at where is hospice provided. 66% of the time it's provided in a person's home. About 17% of the time it's provided in a nursing facility, long-term care. About 13% of the time, it's in a freestanding hospice facility. About 12% of the time, it's in an assisted living. And then about 2% of the time, the person is in the hospital. They may be in a homeless shelter. They may be in a correctional facility. They may be living under a bridge somewhere. Wherever they are living, hospice will go. I was mentioning the survey earlier, whenever they ask Americans where they would prefer to die, and over 80% of Americans have said in 2022 that they would prefer to die at home. The way that hospice is set up is it is run by an interdisciplinary team, and that is called the IDT team. And they then develop a plan of care, or a POC. And again, it depends on that individual, their needs, and the needs of the family. That IDT team meets and discusses every patient at least every 14 days, and some hospices meet every single week, and they have an IDT meeting. So who's on that team? With hospice, there is a medical director. That medical director certifies the patient as eligible and gives direction and support, writes orders, and visits the patients as needed. There's also a director of patient care services, and this person manages the team of providers, supervises that patient care staff, and makes sure that care is delivered according to that plan of care, or that POC. There's also a nurse case manager who manages all the care provided by provides skilled services. They supervise the LVNs and the CNAs, and they coordinate with the social worker. They also have what's called HHAs, or home health aides, and they help with ADLs, or activities of daily living. They come into the home and may provide showers, companionship. They may do some light housekeeping and assist at meal times, depending on the hospice and how they're set up. There's also a social worker who's on staff, and they provide that emotional and mental support and counseling for the family as well as the patient. They can help with financial evaluations. They can assist to find all types of resources. They organize transfers if someone is going from one place to another. They organize the admission to facilities, and they can organize transportation. There's also a spiritual care coordinator with hospice, and they provide, along with that social worker and the nursing team, emotional and spiritual support. They coordinate with religious affiliations. They're non-denominational. They have prayer support, and they can also assist with funeral planning and even do the memorials. There's a bereavement coordinator on staff, and they will follow the family after the patient's death. Most hospices, you will find that bereavement coordinator keeps them on service, keeps the family on service for 13 months after the death. Think about why it's 13 months. Getting through that 12th month, getting through that anniversary of the death, getting through those days and weeks leading up to the death, plus 1 month. They'll keep you on service. Providing emotional support, many times they have support groups, and they help you deal with the grief. And I don't know that I've ever known any of them that says at 13 months, if you're asking to stay on service, nope, you got to go. So they typically will keep you on service as long as you need to be. They can also get you in touch with a one-on-one counselor if you need that, or other groups, support groups. And then hospice also has volunteers. They don't provide any patient care, but they provide companionship, and they assist with administrative support. Sometimes they may do special projects. I got started in this field by being a volunteer with hospice, and I would go in and sit with families and sit with patients. The number one thing that I was asked to do as a volunteer when I went in and out of people's homes, in and out of nursing homes and assisted livings, was to read to the patient. And it almost was always the Bible. They wanted the Bible read to them. I've got right up in the bed with people and had them holding their Bible while I read their Bible to them, providing companionship, one-on-one time, letting them talk to me about things that maybe they couldn't even talk to family about because there was too much of an emotional attachment. So volunteers play a huge role with hospice. Some things that hospice help with. They are experts in symptom control and pain management. I've got a video I show again during my 11th hour training where we say, if someone says that the pain is so bad it cannot be controlled, we've done everything. The pain can't be controlled, then they haven't done everything. it can be controlled. We should be able to control the pain and the symptoms in this day and age. That's what hospice is about, is comfort measures. Hospice is going to help with skin breakdown, nutritional counseling, those ADLs, activities of daily livings, as the aides are coming in, social and family problems. They can do family mediations. That need for companionship, that's where the volunteers come in. Current and anticipated emotional and spiritual needs of the patient and the family. They can help with the paperwork of the advance directives, the DNR, the powers of attorney. They also can provide medical equipment. Respite care can be given for the caregiver to have a break or to get some symptoms under control. They will help with safety issues and instruct families on how to provide care, especially if somebody is going to be at home. That social worker, the chaplain, nurses, they may go in the home and kind of do a sweep of the home and just help with some safety issues. Hook families up with community resources. Quality of life by providing physical therapy, occupational therapy, or speech therapy, not as curative, but as a comfort measure. It can still take place. They are there 24 hours a day. They help with stress management. They help with funeral planning. And then again, they offer grief and bereavement counseling. Let's look at the levels of care. There's routine hospice home care, and this is the most common level of care, and that's when hospice is in the home. There's continuous home care, and this is where sometimes people get confused because Medicare used to provide a continuous care nurse at the end of life, where Medicare would pay for a nurse to be bedside with the person as they are dying. And they stopped that benefit years ago. It's been since I've been doing it. They stopped that benefit. You can still qualify for continuous care at the very end of life when the person is imminent, if their pain or their agitation is uncontrolled, if they are needing someone sitting bedside, able to give meds, there are still ways to qualify for that, but most of the time they don't. Let's look at that continuous home care. This is care that's provided between 8 and 24 hours a day, again, to manage pain and other acute medical symptoms. Predominantly nursing care with assistance from caregivers and aides. This is during a time of crisis in the home. This is when sometimes families will choose to go to an inpatient hospice. They may choose to go to that inpatient hospice, and that may be where they stay till the end of their life, or they may go into an inpatient hospice for a few days to get some pain under control, and then they'll come back home to pass. And that's the next one, inpatient respite care also. It provides temporary relief to the patient's primary caregiver. It can be provided in a hospital, in a hospice facility, or in a long-term care facility where there's 24-hour nursing. And the social worker can arrange that. And then there's general inpatient care. And this is provided for pain control or other acute symptom management that cannot feasibly be provided in any other setting. Again, this is when they're going to an inpatient hospice. It is only used when other methods are not sufficient. And again, it can be provided in a hospital, a hospice facility, a long-term care facility with 24-hour nursing. So who pays for hospice? The majority of the time, the person is on Medicare. The majority of the time, but not every time. They may also be on Medicaid. What if they're under the age of 65? That's a question I get asked all the time. Private insurance, their private insurance may pay for it. They may self-pay, or what typically will happen if somebody is under the age of 65 and needs hospice, that we can find a hospice that will provide it free, where they give free care or a very, very reduced rate. But Medicare covers 100% of hospice services with no copay. But let's look at what is not covered. What's not covered are brand name medications with no generic. That's not covered. They do not cover the nursing facility room and board. If they are placed in a nursing home and they go on hospice, they don't start paying for their room and board. The care unrelated to the terminal or related diagnosis, they're going to provide care for the diagnosis the terminal diagnosis. Care sought without consulting and approval from the hospice team. If somebody just decides to go off and family member decides to make an appointment with somebody and they don't consult hospice, they're not going to pay for that. And then curative or aggressive treatments, because that's not what hospice is about. Common barriers to hospice care. This is, again, we're going to do the top 10 myths, but this is usually the barriers that we hear about hospice care. Fear of taking away hope. And I've heard that so many times that if I go on hospice, it means we're giving up hope. That's not what it is. Death versus failure. I don't want to disappoint or let down my misconceptions about hospice, and then lack of consistency between physicians. So how much care is received? And again, we saw earlier that a person can qualify for hospice whenever that medical team feels like there's about 6 months left. I've known people to be on hospice for 2 and even 3 years before, because each time it's time for them to requalify, they were a little bit worse. But look at these numbers. So many times, look at that highest number, 27.9% on service for 1 to 7 days. Think about what that means. That family, they're not going on hospice until they're imminent. They're not going on hospice until they are dying. Because people hear the word hospice and they're afraid of it, and they think it means that they're dying right now. And so families will put it off and wait to receive this. And it is an extra layer of care that we could have been receiving for months. Now, because we specialize in memory care, one thing I do want to add here, I put it at the bottom. Patients with a principal diagnosis of dementia have the largest number of days of care on average, and we're going to look at that. Because when people are placed because of their dementia, those teams in those nursing homes, assisted livings, are usually pretty good at suggesting and talking to the families about hospice long before they are imminent. So why might a person discharge from hospice? And it does happen. Had this happen before with patients. Sometimes they'll come off of hospice because they're just switching to another hospice. They're going to go to a different hospice. Maybe they're not happy with the one that they've got. And you can do that. You can change hospices. That's not a big deal. Now look at this, 5.6% of the time, they're no longer terminally ill. Now, what in the world does that mean? We had some people go on hospice at the very beginning of the pandemic, whenever we had to shut down and they were no longer able to see their family and friends. And we had people go on hospice. And we've soon discovered, when we were able to get their families back in and they started to get better, the reason that they had taken a turn for the worse was because their family and their friends weren't there anymore. And people actually, it's called, graduated off of hospice. Now, did they still have dementia? Of course they still had dementia, but their circumstances were better and they were no longer at each where they requalified, they weren't continuing to get worse. They'd plateaued again. So they could graduate off of hospice, and then they can go back on hospice whenever they are starting to decline. About 2% of the time, a person will move out of the service area, and then 5.7% of the time, the family will revoke hospice for a hospital treatment. So what does that mean? Let's say my mom is on hospice and she's in a nursing home and she falls, cracks her head open, and she needs some stitches or she needs some staples that they can't do at the nursing home. We're going to come off of hospice, go to the nursing home and get that done, because when we're on hospice, we don't have any more hospital visits. Then she's going to come back to the nursing home, go right back on hospice. And it's easy to do. It's not that big a deal. Hospice is used to this. They do it all the time. Let's move into these myths, because I want to make sure that we get to these myths. Top 10 myths about hospice. If a patient lives longer than 6 months, he or she will automatically be discharged from hospice. You heard me say that earlier. They've got unlimited 60-day recertification periods. They may come off of hospice at some point to go back on it later. Hospice is only for dying people. The hospice is also for the family. They take care of the patient and the family. Here's a myth. If a physician orders hospice for a patient who lives longer than 6 months, the physician will be in trouble for fraud. No, they won't, because many times a person will live longer than 6 months after they have gone on hospice. All that physician's doing is stating that they believe their prognosis is 6 months or less. Patients on hospice can no longer go see their doctor. Hospice actually encourages patients to continue to see their doctor. If it comes to a point where the patient can no longer get to the physician's office, though, the hospice nurse keeps the physicians updated. So you can still see your own doctors while you're on hospice. Another hospice myth. If patients go on hospice, they can no longer seek any treatments. Let's look at this answer. Symptom management and pain control are the main goals of hospice treatment. There are many treatments that are for palliative use. You heard me mention earlier that a person could still receive physical therapy, occupational therapy, and speech therapy. It's all how the order's written. Only curative treatments cannot be sought. That's the main thing here. Comfort treatments are still sought, but we're not doing curative treatments. Hospice is only for those who can accept death. Hospice, a person doesn't come in and go on hospice and then they've got just this magic formula where they've automatically accepted death. But part of what those hospice professionals do is to help people get to that point. But they allow the family and the patient to move at their own speed. They don't push them towards anything. They meet them where they are. Hospice is all about living. And many people who go on hospice, especially the families, have not made the decision that they are accepting death. That's part of what the hospice team helps them do. Hospice is for people who don't need a high level of medical care. That's most definitely a myth. Hospice is a very serious, high level of medical care. They are the best at that palliative care, symptom management, and pain control. Another hospice myth, hospice is when there is no hope in sight. This is one of the most common ones that I hear. So when somebody is terminal, we've got a couple of choices. We can yield to that hopelessness, or we live life as fully as possible until the last breath. And that's what hospice is about. It's not about giving up. It's about having quality of life. And I put on here on that last bullet point, it's actually a gift of hospice, is its capacity to help families see how much can be shared at the end of life through personal and spiritual connection and sharing. I have had families tell me, husbands and wives, tell me before, it's been some of the most intimate time of their life to be with their loved one as they've died. It's all how we look at it and reframe it. Here's a myth. Hospice care is expensive. We've already gone over that. Most people who use hospice care are over 65 and entitled to the Medicare benefit. But even younger patients can use private insurance, or they can get it done pro bono, where they are not having to pay for it. So those were the top 10 myths. And now I want us to look at the frequently asked questions. What does hospice really do? And some of these we've answered, but I just want to touch on a few of these again, and I'm going to try to leave some time for questions. And if not, I will stay on for questions. What hospice is doing is they come in and they have this specialized team to help control symptoms. They are there for emotional support and spiritual support. They're there for psychosocial interventions. It's a holistic team. How do I know when it's time for end of life? Again, we've talked about whenever the medical team feels like they're 6 months or less. Some more of the frequently asked questions. Where is hospice care provided? We've talked about that. Most common in the home, but it's wherever the patient is. So are all hospices the same? We saw the number earlier about there are hospices that are for profit and there are some that are not for profit. But for the most part, they all go by the same general philosophy. Their services may differ. I worked for a hospice one time who provided music therapy at end of life, but that's not something they have to provide. It was just something they provided. I have been with a hospice before that provided massage therapy. Not something they have to provide. It's just one that they provided. So they may have some different services that they provide. Can pain and symptoms be controlled at home? Most of the time, yes, they can be controlled at home. If a symptom, pain, nausea, vomiting, difficulty breathing becomes a problem, hospice nurses can be reached 24 hours a day, 7 days a week, and most symptoms can be controlled without injections or IV medication. Because you heard me say earlier, we are all about comfort. Now, sometimes if that pain or the agitation gets out of control and they go into inpatient hospice, they may use an IV, they may use an injection. But for the most part, what you'll find is that pain and agitation and symptoms can be controlled with medicines that go under the tongue and they absorb, creams, patches. What happens many times is that the family starts to panic because death doesn't look like what they see death on TV looking like. Death is not always, here's how I teach it. I say, just like birth doesn't look good, sound good, or smell good sometimes. And death doesn't look good, sound good, or smell good sometimes. But the patient will tell you if they're in pain with their body. Furrowing of the brow is the number one thing that we watch for when we're sitting bedside with someone. But sometimes when a person is maybe making noises because of the congestion in the chest, it's bothering the family that's in the room, but the patient is fine. They're okay. It's just their body starting to shut down. Or the family starting to panic because they're saying they haven't had anything to eat or drink. And we come in and we do education. And especially with dementia, we talk about a person with dementia doesn't die because they stop eating. A person with dementia stops eating because they're dying. And digestion's that first system that shuts down. They don't need fuel anymore. The body knows how to do this. Hospice talks you through that so that you understand what's happening, because it isn't like it is in the movies and on TV. Another question that's asked a lot is, once they go on hospice, do I have 24-hour in-home care? And you don't have that, but you do have team members who come in and out. You have those home health aides, and you have nursing, the social worker, and the chaplain. Can I live alone and receive hospice? You actually can, but you do have to have a plan and prepare for a time when that illness gets to the point that there's going to need to be 24-hour care. And can hospice patients choose to return to a curative treatment? Yes, they can. If somebody goes on hospice and then they decide that they want to maybe go try a new treatment, a new chemotherapy, or a new radiation, or maybe they just want to go back on treatment for a while, they can do that. They can go back to curative treatment. They may just switch and go to palliative care, because with palliative care, you can be receiving a curative treatment. And then if they choose to come back to hospice later, they can do that too. Some more questions. Can I go to the hospital and still receive hospice care? We talked about that earlier. If you go to the hospital, you revoke or you come off of hospice, and then when you come home or back to the facility, you go back on hospice. Most of the time, though, the hospice team can handle or take care of whatever is needing to be done. Is the decision for hospice care giving up hope or wanting to die? I mentioned that one earlier about giving up hope. That's not what it is at all. Hospice is about living. It's about bringing comfort to the patient and to the family. And actually, many times what we'll find is that patients many times will feel better whenever they have good pain and symptom management. It's about care and support. It's very different from other types of care. Another common question, does hospice do anything to bring death sooner? No. The goal is to alleviate the suffering and to manage the symptoms. It doesn't do anything to speed up the dying process. It's keeping a person comfortable. They come in and they lend support and they allow the disease process to unfold as comfortably as possible. I've got a program that I teach where we talk about that death itself is not painful. Death isn't painful. Disease is painful. Disease is painful. So if a person has had a painful disease, that's what may be painful at the end of life. But death itself, dying, is not painful. Do I have to be homebound to receive hospice care? No, we talked about that you can actually receive hospice care anywhere. Does hospice provide support to the family after the patient dies? And we talked about that they should stay on service for 13 months so that you get through that first year plus a month. Another question we get asked a lot is, what is the difference in hospice and palliative care? And hopefully at this point in the program, you know that. Now, here's something different also. Palliative care isn't defined by that 6-month hospice benefit where they're requalifying. A person can be on palliative care and stay on palliative care. It's treatment that enhances comfort and improves the quality of life of an individual who's facing a serious illness, and they may not qualify for hospice at the time because they may be continuing treatment. And that's okay. That's what palliative care is for. It doesn't have to provide the same services as hospice, such as that IDT, that interdisciplinary team. So they may not have the spiritual services or the social workers available, but they have that nursing team available. And if you think about it, all hospice is palliative because it's all comfort care, but all palliative is not hospice because a person can still be receiving treatments. I did want us to see the reasons that people go on hospice, and these numbers had really changed when I updated this yesterday. You'll also see that I added on days, and this is something that they are measuring now, what a person's on hospice for and how many days on average they're on hospice. So I had these in the order of how they have been, but now that order has changed. So terminal illnesses where the person is on hospice. So about 8% of the time it's cancer, and their average stay on hospice is 55 days. That's how you read this. About 9% of people on hospice have a heart disease, and their average stay on hospice is 129 days. Now look at dementia. Dementia now, that is 18.5%. So about 19% of people on hospice have dementia, and their average stay on service is 181 days. And we said earlier that people who have dementia typically are on hospice longer because they have medical teams who know when to tell them that it's probably time to get on hospice. COPD, or pulmonary or respiratory disease, about 6% of people on hospice, and they're on for about 146 days. Stroke and coma, renal failure, and here's a new one, COVID-19. This was not on the list. but now it's on the list. And it was just 0.9% of the people on hospice were on for end-stage COVID-19, and their average stay on service was 28 days. Now, you'll also notice severe malnutrition. You may have heard the term failure to thrive. We don't use that term as much anymore, and that's not a reason that they put a person on hospice. We changed the wording, severe malnutrition, about 1.3%, and those people are on about 77 days. These are just averages. Here are some other terminal illnesses that make a person eligible for hospice when a person gets to the end of their life. And I've got on there that adult failure to thrive. That is whenever they are severe malnutrition. But multiple sclerosis is on there, muscular dystrophy, a non-specific terminal illness. They are just terminal, Parkinson's, ALS, Huntington's, a liver disease, and then that advanced end stage with a debility. There are all of the resources that I used for this. John Hopkins and NHPCO, National Hospice Foundation. Here's our information. You are going to be getting these slides, like we said earlier. I will answer any questions that might be in the chat. You're also going to receive a copy of this. We recorded it. So let me look in the chat real quick.
And while Holly's looking in the chat, there are a few questions. I'll just remind you all this afternoon, you'll receive that follow-up email with the slides, an evaluation and how to get your CE credits. If you want a CE credit, 1 free hour for nursing, social work, licensed counselor, or certificate of attendance, and our upcoming programs that everybody is welcome to join. So,
thanks. Funding sources that cover palliative care, those are all the same as with hospice. And then volunteer hours a week, it depends on the hospice. Because if it is a really big hospice and they've got a big team of volunteers, you may be able to get a volunteer in there every single day. But you might get somebody that you really, really like, and so you work with that person and they're going to come for 4 hours on Saturday or something. But it really depends on the hospice. When somebody with dementia goes on hospice, do they continue to take meds for heart, blood pressure, and diabetes? Many times they do, because that's a comfort measure. If that's going to be something that makes them uncomfortable. Now, sometimes families will choose to go ahead and take them off of some meds, but that's a discussion you have with that IDT team where you talk about it. But for the most part, yes, they stay on all of their medications because those are comfort measures. Hospice companies. For some reason, I can't see all of these. What are your thoughts of corporate hospice companies versus smaller nonprofits? I do tend to lean more toward the nonprofits, just having worked in the field for a long time. There are most definitely some good for-profit hospice out there, but I do tend to lean a little more toward the nonprofits. If someone is diagnosed with cancer and opts not to have surgery or chemo or radiation, qualify for hospice, or does the patient have to exhaust all treatments first? No, they don't have to exhaust all treatments. They can choose. They can choose. Can you talk about EKR's last stage of dying, meaning, and how the hospice team addresses that? Yes. That last stage that they came up with, meaning, it's interesting. Think of it this way. Here's a great example that I usually give so people understand meaning. We have an organization called MADD, M-A-D-D, Mothers Against Drunk Drivers. But how did we come up with that organization? Because there were mothers who lost their children to drunk drivers. And that group of mothers needed to find a meaning. That's where meaning comes from. So meaning is when we take the death and we are able to somehow turn it into the meaning for this is, and that group of people created MADD. The other example I give is that light in the back of the car that's up. We didn't used to have it. That's called a Dole light, D-O-L-E, after Elizabeth Dole. There were some people who died in car accidents, and we didn't used to have that light there, and they came forward and they said, I bet if we had a light there, and they got it to Congress and it became the Dole Act, and now we all have a Dole light in our car. So this group of people found a meaning. So that's part of what that is being able to find meaning. It's different for everybody. I also went to a talk one time, and it was the mother of one of the shooters at Columbine. It was the mother of a shooter, not one of the victims. And she said, I lost my child that day too. But nobody stops to think about that. Meaning. So she had to do something with her grief. How hard of her, how vulnerable that makes her to go out and speak to people when it was her son who was pulling the trigger. She had to be able to find some meaning. Let me go back. When a patient changes to curative, picks up all the DME, and when they return from the hospital. What is the easiest way to make this a seamless transition to curative, or if the patient decides to go back on hospice care? Yeah, that one, when you're dealing with the DME, see where a patient changes to curative care and the hospice picks up all the DME. That is where I would sure be staying on the social worker and the nurse to make sure that they get to make sure that they still have everything. And possibly if they go back to curative, but they stay on palliative care, I would try to negotiate that they keep everything also. Can you tell nonprofit versus profit when one wants to donate? List of hospice providers. Yes, there are lists of hospice providers. I'm trying to think of the easiest way to get one. I know the Alzheimer's Association has lists that you can look at. Jamie, do you know specifically of just a list that's out there? Yes, please do share these. We encourage you to share our slides. Just please leave it on our slides, because our logo and everything's on there. You can also share the video that we send. Can a family member be considered a volunteer? Yes, a family member can be considered a volunteer. They're going to ask you to go through training. They're going to want you to go through their training. Go to a private doctor. Is that doctor covered by Medicare or hospice? You can still see your private doctor. Normally hospice isn't going to pay for that, but Medicare should. Yes. Presentation. Could the meaning also be reflective on the individual and their life, focusing on their life? Absolutely. Focusing on their life, the life lived, and the legacy during that time. Yes, it doesn't have to be that they go out and they start an organization or something major like that. I just use that because most people can understand that. Thank you. Someone with dementia who also has stage 4 chronic renal failure, and the family has decided not to do dialysis. Failure, would you suggest we look at hospice and decide on a hospice organization now? Yes. And again, you can always ask for a hospice referral, and they come out and they say they're not appropriate at this time. Didn't hurt anything. And they'll tell you, when they get to the point that, then they'll be appropriate. And they don't charge you for that, but they'll come out and do a consultation with you. Information. Thank you. Thank you. Thank you. And if anybody has any other questions that you think of, we are here. We are both working at home right now because I can't get out of my driveway. But you can email us. They're on the slides. You're going to get our number and our email and a copy of this program later this afternoon. Jamie, something you want to add about the CEs?
No, we just asked everybody complete the evaluation. We really appreciate your feedback. But if you want a CE credit, you must complete the evaluation so we can process your information.
Perfect. Thank you. And she'll also send information about upcoming programs and our support groups. Our support groups are open to everyone. We've got people that come on from all over to our support groups. So we appreciate you being here today. Thank you very much. If you think of something else, please send me an email. Bye.